All right. Well, thank you, Betsy. Again, I am Eric Peeples. I am currently at Children's Nebraska, and I did not bring the 9-foot polar bear costume to this. I'm thinking maybe I should have. So, as Betsy set this up, our goals for this part is to try and help kind of build the baseline of kind of what we know about HIE going into the session this afternoon of what do we now want to add to that? What are the biggest gaps? What are the biggest questions we still have to continue to ask and to continue to evolve our understanding of this problem? Want to celebrate what's been done because what's been done is fantastic and is what's brought us things like hypothermia that are helping so many babies today. But again, the biggest piece here is what are the remaining gaps. So starting off at the highest level of what is great that's gone on so far. And you can see here, so this is a graph of how many publications per year over the last, what is that, about 40 years, have been published on either hypoxic ischemic encephalopathy, or as you heard Betsy say, the more umbrella term of neonatal encephalopathy. And you can see both the sheer numbers, but also the increase over the last many years. And so there are a lot of people working very, very hard to try and answer questions around HIE. Now, what is the bad of this? Is that despite the almost 2,000 and sometimes more than 2,000 manuscripts per year that are being published on this problem, since 2005, we have zero new interventions that have been proven to be effective for babies with HIE. And so 2005 was when the NICHD trial was published for hypothermia, and that continues to be our only proven intervention at this point. So we're working really hard, and there have been a lot of advances that we'll talk about, but they haven't necessarily been in the intervention sphere. And partially because of that, this is not to pick on any one intervention in particular, but there are interventions that are being promoted outside of what the actual data suggests are beneficial. And so I think that is in part because a lot of families feel desperate that we don't have more to offer. And so they're looking for anything. And there are people that have attempted to maybe monetize that. And I think especially with the internet, it's very difficult to tease that out sometimes. So over the 50 minutes that we have, Danielle and I are going to try to cover all of this literature, which I worked out to be about 1,300 papers per minute. So that is not drinking from a fire hose, that is drinking from 10 fire hoses. So we'll do our best, but please be patient with us. So again, we're going to break it up into the sections that are going to be the same sections you'll see in your breakout groups this afternoon. And so the first one I'm going to start off with is causes and prevention of HIE. And there are a bunch of things that go into this. The first one up here is perinatal versus postnatal, and meaning those injuries that happen at or around the time of birth as perinatal, or those where a baby is born, seems to do well for a period of time, days, weeks, months, and then has something that happens where their heart stops. They lose that blood flow, the oxygen to the brain, similar to what happens at or around the time of delivery. But why it's important to distinguish is we have literature that says that older children, 5, 10, 15 years old, when they come in, hypothermia is probably not terribly effective for them. And then we have literature in our world that perinatal hypothermia is effective. And so where is that switch? And when we don't know at this point of if a baby is 10 days old when that happens versus 10 months old, is hypothermia effective, or is there another therapy that is effective? And that's a big gap that we have right now. Severity is a big one we talk about. You heard Betsy talk about some of the cool prime and the mild encephalopathy work that's ongoing, and that is a big piece because they were not included in those initial hypothermia trials. So we're trying to get more information, and I'll talk a little bit about some of those here coming up. But you can see I stole this off of the Hope for HIE website that kind of breaks down the mortality, disability, everything by groups, and you can see mild certainly has disability, and I think there are some studies that are showing sometimes even higher than this 5 to 10% that you're seeing. And so it is a real problem, and it's a problem we don't have an answer for right now. And there are lots more answers we still need for moderate to severe as well. Part of the difficulty with what we have in looking at severity is the difference in definition of severity. And so pre-hypothermia, when we had all this time to diagnose the severity, the SARNAT score that we tend to use a modified version of now to determine severity allowed for the worst severity over the course of the first 7 days, the first week of life. Now we are forced to make decisions on severity within the first 6 hours in order to determine whether or not a baby qualifies for hypothermia. And so some hospitals will use that initial diagnosis of mild, moderate, or severe prior to hypothermia initiation to make a decision as to the overall severity. Others still use that 7 day period. And so we now are kind of split between different studies and different hospitals as far as who's using what types of definitions for severity. And so we certainly need to figure that out as a community. And then again, back to the Hope for HIE figure here, you can see that it's broken out into high income countries and low and middle income countries. And that's important for a lot of reasons, including you can see that the mortality and disability is higher, especially in that moderate category in the low and middle income country group. But also, as we'll touch on here in a little bit, a big trial came out a few years ago that showed that hypothermia was not as effective in that population and in fact increased mortality in the countries that they looked at. And so there's a lot of questions around how do we help with the burden of HIE in those low and middle income countries. And the last piece on this slide is the different types potentially of HIE that can come out in the different patterns of brain injury. And so on the left, you see that brightness in the watershed areas. And so what watershed is just those areas where you're in between two big arteries. So you've got blood flow coming from here, blood flow coming from here, and there's an area in the middle that's a little bit more sensitive to decreased blood flow and oxygen because it doesn't have as big of arteries coming to it. And so you can see those areas are hit more. We think that that's probably most associated with a chronic low oxygen and low blood flow state, as opposed to the classic kind of acute or quick injury that we think of with most HIE, which is I give the example of a cord, an umbilical cord coming out of the cervix, getting compressed right at the time of delivery. The OB releases that, delivers the baby. So very short, but of pretty severe injury. And that tends to present in that middle picture of what we call basoganglia thalamus, BGT, deep gray. There's lots of different words for it, but you can see kind of the deeper parts of the brain that are further in are the most injured. And then you also have babies that are diffusely injured, where we see that injury all over, and that's an example there on the right. So again, talking about causes, but also prevention. Betsy mentioned that we need OB partnership, and that's something that hasn't been as productive in the early years of the research, and I think is making big headways. And these are some of the, I'll still call them early-ish trials, even though they were 1 and 2 years ago, in looking at how can we better manage the pregnancy after moms present to the hospital for delivery. The study on the left is looking at babies of moms who presented with an abnormal fetal heart rate at the time that they first came to the hospital. So the CTG is the fetal heart rate monitor, and they're specifically focusing on here in this graph those that were normal. So they didn't already have something going on, they don't think, when the mom came in, and then developed something during the course of the hospitalization. Now, some of those had what we call sentinel events. So again, a cord prolapse or the cord coming through the cervix is a great example of a sentinel event of something we see that we know is potentially causing hypoxia and ischemia. Those that didn't have sentinel events, they broke them out into, did somebody do something different? Did they say, okay, we're not doing a vaginal delivery, we're going and doing a C-section? And if they did, was that what they called timely? Did they recognize things on time, or was it delayed? And what I want you guys to get out of this are two things. One is there is a group of those moms where we think we could do better. The potentially avoidable HIE, the if the obstetrics care was able to evolve a little bit, we might be able to avoid some of those. But the other piece is this is not all on the obstetricians by any means, because you can see that other half there on the left that they turned non-avoidable. And so there are still things that we're still going to have HIE even with perfect obstetric care. And then on the right, one of the things that they've looked at of trying to improve that obstetric care is actually doubling up on the heart rate monitoring. So not just the fetal heart rate, but also mom's heart rate, so that they can differentiate and see, because sometimes they're worried that maybe the heart rate they're looking at is mom's and not baby's, or vice versa. And so if you're looking at both of them and then you see they merge together, you know something's happening. And so they, for several moms, 62,000 moms. They looked at mom and baby, and they saw actually a decreased rate of acidemia, so acids in the blood, or HIE in those moms where they were doubly monitoring. And then one of the few things that we've looked at for in the delivery room, this is cord milking, of trying to give a last minute large bolus or volume of blood to the baby from the umbilical cord itself right before cutting the cord. And Anoop Kathiria out in San Diego had shown that there may be a slight decrease in HIE when you are doing this in a group of babies who were clearly under distress at the time of delivery. So very early stuff as well. There's lots of things that need to be teased out about this, but promising. And the last big piece of this section that I wanted to cover is genetics. And so Betsy already mentioned the overlap between genetic diagnoses and HIE. And the study on the left showed that in those babies where they did a full exome or genome, so looking at all of the pieces of the DNA, were they able to see a genetic diagnosis? And in a quarter of them, they found not only something that was different in the DNA, but something that was different in the DNA that would likely present very similar to HIE. And so that's that middle group. And on the right is a review from Dr. Michael Pepper in South Africa, and his group looked at kind of all the literature we have, all the different genetic diagnoses that may be overlapping or associated with babies who have HIE. And so again, just because they have a diagnosis doesn't mean they didn't also have HIE. But it's good to know kind of how those two things interplay. And that's something that I think is really just starting to become more recognized. So again, ton of questions that we still have in this small section. And this is the longest one that I'll touch on, just because of how little we still know here. But I think the diagnostic criteria for HIE is a big one. It's going to take a huge lift, but I think is going to be revolutionary for the field to have actual strict diagnostic criteria so that we can better diagnose and treat these babies. The next section is detection, diagnosis, and prognosis. And so this revolves a lot around diagnostic biomarkers. So this top figure is from the AAP, American Academy of Pediatrics guidelines that just were recently released, and shows kind of the main things that we've been working off at this point, which is the pH of the blood, the level of acid in the blood, as well as the base deficit, which both get at kind of the similar question. APGAR scores that we assign in the delivery room, are they low? Are we continuing to need ventilation for the baby for the first 10 minutes? And then you can see at the very top the suspected acute hypoxic ischemic event, or the sentinel events that I referred to previously. And then bottom left there, we do our exams. We talked about the SARNet exam. There's a lot of variability here in that there's multiple versions of the SARNet exam. We have Thompson scores, we have Sibin scores, the NICHD score. There are a bunch of different ways that we can look at neuro exams. So even that in and of itself has not yet been fully standardized. And then some units are using amplitude integrated EEG or brainwave monitoring to try and help with early diagnosis in those first few hours, as well as some blood tests. So I put troponin up there. It shows cardiac stress, not necessarily as a diagnostic marker for HIE itself, but to diagnose other organs that are injured at the same time as HIE. There are a ton. So when I showed that initial slide with all the research, probably 75% of that is people trying to find some biomarker that is, I don't know what that noise was, but some biomarker that will help us understand both diagnostically, so is this HIE, but also predicting the future. And so we've got all kinds of omics, the genome, looking at the DNA. The DNA gets transcribed into messenger RNA to be able to create proteins. So the messenger RNA is the transcriptome. Proteomics is obviously protein, and then all of the other things that the brain is doing to chew up food and create other things after it is the metabolomics. So things like lipids and calories and those kinds of things that go into the brain. So you can detect those things in the blood. None of those, there's no single one of those that has shown benefit in prognosis. We use MRI, as you heard, is a big one to try and prognosticate, as well as something called MR spectroscopy. So in the MRI as well, they can actually detect the levels of some of the metabolic waste in the brain. So some of the molecules that are along with the metabolomics. And then EEG and AEG is a huge prognostic feature. And so hopefully we can find a mixture of all the three of those things that can ultimately give us better prognostic understanding. And then what are we prognosticating for is a big one. Of right now, we're using things like Bailey scales, the WIPSI, the IQ scales, those kinds of things moving forward. The question is that what matters most? And are those actually reflective of what are really important family-centered outcome metrics? And so I think Danielle will talk a little bit more about this in her piece. But I think when we're thinking about prognostic markers in the NICU, we need to be thinking about what are we markering for? What is that goal that we're looking at? And so lots of questions here as well around both diagnostic and prognostic markers. Uh, Thinking about clinical trials, being able to have a marker that says, okay, this baby responded appropriately to therapy or didn't, so that we can talk about using a supplemental or additional therapy. Some of those things would be really valuable moving forward to advance the field. And then the last section that I will touch on, the third of six, is treatments. So developing, evaluating treatments. I'll take a moment here at the beginning, to talk about the development of therapeutic hypothermia, not only because it is the most important thing that's happened to our field at this point, but also because of how beautifully it came together. The fact that it went right down the pipeline of what we would expect a therapy like this to be able to go through. Of It took longer than we would have wanted, 56 years, but going from the small animal models showing benefit there, going to larger animal models showing benefit there, translating to humans, and showing great benefit in humans as well. And so beautifully done, a ton of work that went into there, but that is exactly what we're trying to reproduce with many of these other interventions that we're trying to look at. But again, the big limitation that we've run into, or one of the big limitations with hypothermia, is there on the right. That is the increased mortality graph from the Helix trial in low and middle income countries. And so there's definitely lots of work in hypothermia still to be done. There's things that we have done so far that we've maybe ruled out, or at least said that probably are not going to be helpful. On the left is the longer and deeper trial from the NICHD that looked at cooling. longer than 72 hours and deeper than that 33.5 degrees Celsius. Both of those showed increased mortality, and so that was stopped, and we currently still use the 72 at 33.5. The middle graph is the potential for treatment benefit for late preterm infants. And so that shows kind of the high point there is 74% that it's not helpful and may be harmful to cool late preterm babies. And then on the far right is the very little data that we have so far on mild encephalopathy, which in this one marker that they've looked at, again, that MR spectroscopy that I mentioned, they didn't see benefit in mild HIE when they cooled them, but there's lots more data coming out and much bigger cohorts that should be coming out. So very little that we know. Hopefully we'll know lots more soon. And then medications, interventions. The neuroprotective medications, we know about the HEAL study. Betsy mentioned that that was looking at erythropoietin as a supplemental therapy on top of therapeutic hypothermia that unfortunately did not show great benefit in the primary markers that they looked at. One of the real powerful things that come out of these big studies, though, is we get all kinds of other secondary analyses of these data that really help in other ways, and we'll talk about that moving forward as well. Well, there's a ton of other medications that are currently being tested in the pipeline, both with and without hypothermia, because again, especially for low and middle income countries, we are still on a search for something that would help potentially instead of hypothermia. So this is, I just wanted to call out this quickly. Again, the pipeline of moving from cells to small animals to large animals to clinical trials is something that Bill and Melinda Gates Foundation has supported in 3 different labs throughout the world, looking at in vitro studies with Enka Pasca in California and small animal studies with Hemen Sabir in Germany and large animal studies with Nikki Robertson in the UK in trying to push quickly some of these medications through that pipeline to try and get some of the ones that are most likely to benefit our babies in the NICU. These are some of the other clinical trials that are going on right now. The Cool Prime we've mentioned a few times. Acumen looks at melatonin, albino looking at allopurinol, study getting off the ground looking at hydrogen. The top right are the Comet and the Time trial. They don't have cool little logos like the other ones, so we need to talk to them about it. Both of them are looking at mild encephalopathy as well. And then the STAR trial, also I created their logo for them. They can thank me later. And then all of those are neuroprotective. Neurorestorative is different. That is, after hypothermia or in that later phase, we can maybe still make some progress in benefiting the brain. The biggest one there is stem cells. And so I know there's a lot of talk about that, a lot of questions about that. Did want to speak real quickly on that as well. A couple of different ways that we can get stem cells from the umbilical cord, from the bone marrow, from created in the lab in cell culture. Ultimately, they all come out. There's limitations and benefits to each type. Ultimately, they come out into a stem cell. They get administered. Some people are trying that IV. There's a really interesting study in stroke, in neonatal stroke, that looked at intranasal, so injecting it into the nose. Ultimately, again, resulting hopefully in neurorestoration. We have not had a lot of terrible success in this field of research, in large part because a lot of it was focused on umbilical cord and self umbilical cord. So essentially taking the umbilical cord blood from the baby themselves and giving it back to them. The intensity of taking those stem cells out in a clean and appropriate way is something that not a lot of places can do. And so we haven't had a whole lot of headway, but with some of these other things that are coming out and some of the signaling molecules that stem cells create, harnessing those may be beneficial. And then really the only other one that I am aware of that's really targeting that later phase is our helpers at this conference, Neurin, have this molecule NNZ-2591 that's going through FDA approval right now to hopefully get some clinical trials going up on that. And then there's a million things that we do in the NICU for these babies outside of therapies. All of them can help improve their neurodevelopmental outcome. And so this is from a really nice paper that Pia Wintermark and the Newborn Brain Society had created, just to show that there's a ton of other things that we need to know about. So all kinds of questions on this one as well, and we can hit more on this in the afternoon session. But now I'm going to upgrade your speaker to Danielle Barber.
Okay, I don't know about upgrade. I don't know how many of you guys are used to sitting in a chair and listening to people talk for hours on end. So if you want to like stand up and stretch for a second, that's also okay. Yeah, my son definitely needs to stand up and stretch. Yeah. Okay. Um, all right. And feel free to get up and get drinks and as we go. Okay, I'm going to take us through three more topics. And this is really, as Eric said at the beginning, a whirlwind and just, oops. Yeah, you can grab it for him. Just put it on the table. Um, it's a whirlwind. Some spots have a lot of papers, and I couldn't pick all of them, so I just picked a couple. And some spots don't have a lot of papers in HIE, and so I'm borrowing from related fields where this is as close as we can get the best of what we know right now. And really, the goal here is to keep all these questions in mind as we get into the afternoon session, because this afternoon we want everybody to be putting your brainstorming hats on and be asking a lot of questions. Be thinking about what are the things we don't know? What are the things that we need to know? And how do we decide what are those most important things that we need to prioritize? We can't answer all of the questions, obviously not today, and even not in the next couple of years. But what are those questions that are most important for us to be able to start to get answers to? Okay, so um, first, next topic that I'm going to cover is monitoring and follow up. You left the NICU with your child, and now what? What do you do? How do you follow up? Um, so thinking about what are the best strategies for following up after the NICU, um, I didn't find any papers that are specific to HIE. What does the best follow-up look like for HIE? The best we can do is looking at NICU follow-up programs that are primarily focused not only on kids who had HIE, but on kids with lots of different reasons for being in the NICU. The majority of that is encompassed by babies who were born prematurely, right? So what can we learn from those babies? When we look at some groups that have published uh, outcomes programs of how they manage their NICU developmental follow-up programs. Um, there are thoughts on cadences that those programs follow. How often do you check back in with those programs? How often do you have appointments? Who should be at those appointments? Is it a neonatologist, neurologist, physical medicine and rehab doc? Physical therapists, occupational therapists, speech therapists, psychologists, all the folks that you guys know about, and how often do we need to be doing that, right? So those questions still arise. We also know that some literature is emerging that in as we follow these kids for longer, this one is from HIE and not borrowed from prematurity, that developmental follow-up is even kids that have normal MRI, even kids that seem like they're doing okay on those Bailey scales or the ways that we're assessing development early, things can arise later. And so indication that we really need to be following kids with HIE much longer than 2 years old. We need to be going to school age, teenagers, and beyond. Now, coming back to borrowing from other fields, this picture is of Iona Novak. She's an occupational therapist in Australia and a fantastic researcher who we're borrowing from the cerebral palsy literature. She did careful review of an enormous amount of literature. I'm going to show you a couple of slides here of rehab therapies and early intervention. What are the things that are worth doing, right? So on this graph, and it's going to be the same for the next couple of slides as well. Can you see my mouse? Okay. So you can see this is called the traffic lights paper because it's green, yellow, and red, right? They reviewed the papers that existed in the literature until 2019 regarding diagnosis of cerebral palsy and which interventions or therapies are worth it or have evidence behind them. The size of the bubble depends on what kind of evidence and how much evidence there is for each thing. So for each type of treatment, a really big bubble means that there's at least 15 randomized controlled trials to support it. And a small bubble means there's only observational studies to support it. And as we go up towards the top, green, these are the do it treatments, do it interventions. The yellow above this line are things that have some evidence to support them. That dotted line is what Dr. Novak calls the worth it line, right? And below here, there are some that have some evidence but are below the worth it line, and red is don't do it, okay? And so, evaluating interventions, it's always all of us and our children have a limited amount of time, have a limited amount of resources, right? So, time and energy and money that you put into one therapy or treatment is time and money and energy that you're not putting into a different therapy and treatment, right? How do you know where to spend your resources, right? And so that's where this is helpful. So you can see that in motor outcomes and motor therapies and interventions, there are a lot of bubbles here, right? There are a lot of circles. And there are quite a few in the motor realm. And as we go to other fields, we get fewer bubbles you're going to see as we go. So here there's early intervention, tone, contracture, and alignment. And again, the reason that all of those we started with all of those is because this is a paper that is focused on cerebral palsy, right? And sorry, I should have made this point on this slide. This is the reason that Hope for HIE and CPRN work together, because there is an overlap in this Venn diagram, right? There are kids who have CP because they had HIE, right? But there are also lots of kids with HIE who don't have CP, and there are lots of kids with CP who did not have HIE. And so we try to learn from each other and work together in ways that are synergistic. So that's why there was so much focus on the motor in this first slide. And as we keep going and we look at things like pain, sleep, pulmonary, mealtime, drooling and oral health, communication, cognition, self-care or function, and parent outcomes, we get a lot less green bubbles, right? And a lot less bubbles overall, right? And then these are bubbles about preventing cerebral palsy either before birth or around the neonatal course. So still many questions left to go here. Should follow-up for HIE be separate or different from follow-up, NICU developmental follow-up from kids who had prematurity? What are the best care systems to monitor kids after HIE? At what timing do kids need to follow up? What disciplines need to be involved? Which kind of folks need to be part of the conversation? What are the most effective interventions and rehab approaches across various developmental domains? And what are the best ways to educate families or coach those care navigation, how to wiggle our way through this system? Okay, the next bucket that we want to talk about this morning is, so we're at number 5 out of 6, so hang in there. This bucket is about family experience, advocacy, and care. And actually, when I was preparing this section, I was so happy to find that there are parts of this that have a decent amount of literature, decent amount of work in this space, and Betsy is an author on a lot of these papers. So really, a lot of this is work that Betsy has been engaged in, and that folks on our Hope for HIE's medical advisory board have really been doing this work. So this is ways that Hope for HIE is really pushing this field forward in important ways. Okay, so to start this section off, and I hope Maggie will tell me if I'm being too slow or long. Okay, so to start this section off, I wanted to talk about for the individuals who had HIE themselves, our children, or as they grow up to become teenagers and adults, what is their emotional well-being? What do we know about their emotional well-being? This nice paper came out 2 years ago, and they tried to answer that question. They did a systematic review. They looked at all the papers in the literature and tried to summarize that. And they looked at 43 papers with more than 3,200 kids with HIE. Most of what's in the literature is talking about what are the kids' motor outcomes, maybe what are their cognitive outcomes. But this is really focused on emotional well-being, right? So I know you can't read any of the text on this graph. I'm going to tell you that they're looking at three different buckets. The top bucket is socio-emotional, so social engagements and emotional outcomes. The middle one is behavior, and the bottom one is psychological outcomes. And what they did here is when we're looking on the horizontal axis, you can see over time. So the left is from birth, and out here gets to 11 years old. So we're not into adulthood. We're not even into teenagerhood yet, but at least we get to around 11 years old. The green bars are studies. So each one of these colors you see are the data from one study, one publication. And the green bars are where that study found a relationship between HIE or severity of HIE and a change in someone's emotions or behavior or psychology. And the pink ones are studies where there was no relationship. And the gray bars, we see a lot of gray bars, are studies that didn't report anything either way. So the authors of this study, this is a good flag to plant in the ground. This is a good place to start. And the authors of this study noted that even as they were going through this, as they were trying to, like, this is the work that Eric did with with the neonatal common data elements. It's taking things that were done in different ways in different places and trying to make apples to apples comparisons, right? And we don't have apples. So the authors of this study were noting that they're collecting information from all these different studies, and there's no standard approach of everybody's reporting the same thing, right? So that was a challenge that they described. I love this paper, and Betsy and I have spent a lot of time fangirling over this paper. This is a completely different kind of science, right? As opposed to this, which is a long, careful review of a big body of work. This is a description, and this is a description of 4 adults. This paper has 4 little snippets. The clinicians provide a short snippet of what happened to the baby when they were born, what does their MRI look like, and then most of the paper is these 4 used to be babies, now adults, who are describing their own life, who are telling what they've been through, the good, the bad, and the ugly, right? And I love this paper because it really is a beautiful demonstration of that life can be happy and hard at the same time, right? I think that's a lived experience that a lot of us have that I think came through in Laura's performance last night, right? You can have both of those things at the same time, right? So now shifting from the individual's experience to the family's experience. There's some nice work in the literature, this one from Alexa Craig, looking at our current understanding of what families experience in the NICU. This is really still in that acute phase, talking about experiencing the trauma of a difficult birth and the loss of normalcy. We also have literature that describes how the diagnosis of HIE is life-changing for parents, for the family, how we balance hope and facts, and difficulties with struggling to meet our needs, our child's needs, including societal problems, insufficient care infrastructure, and battling disability-based discrimination. Some great work from Monica Lemon, also on our medical advisory board, who tried to understand from families. This came out of interviewing multiple families and coding, understanding how do families want to receive this information? What is the best way to communicate the information that can be uncertain, that can be difficult? And so this is an approach, the Align approach. I won't go through all the pieces, but there are systems in place for coaching clinicians on how to communicate effectively. Also, papers on how to collaborate in care. How do clinical teams collaborate with patient families? Thinking about trauma-informed care, thinking about integrating a palliative care approach into our clinical care. And then our current understanding of advocacy and access to care. We know that here's a paper that showed that while this was a group from California, while 80% of kids accessed therapies like speech, PT, and OT, less than 10% used any psychological therapies. And the folks who participated noted that some of the barriers there were difficulty getting time off from work, lack of childcare, and transportation. This is another one from California, where they found that about 3/4 of infants attended follow-up clinic by age 1, and that there are some disparities here, right? Female infants, those born to African American, single, or less than college-educated caregivers had lower follow-up rates. And so how do we work to closing those gaps? And 74 sounds like a lot, but it should be 100, right? Okay, so questions that we still are unanswered in this family experience, advocacy, and care domain. What is life after HIE like as an adult? This is part of what we want, why we're building the registry. We want to be able to start answering questions like that. What screening tools or assessments are most appropriate? How can we improve access to psychological therapies? How can we improve follow-up rates and improve equity and access? Okay, last one, we made it. Okay, and this one's gonna be short because there's really a lot of room we need to go, a lot of work we need to do. And again, I'm circling back to that place where we don't have a literature yet that's specific to HIE. We're borrowing information from other fields. So this study looking at sleep is borrowing from kids who had neonatal seizures. Now, a lot of these kids are kids who had neonatal seizures because of HIE, but it's not exact, it's not that perfect Venn diagram, right? There's some overlap. So of these kids who had neonatal seizures, more than 60% at early school age had parent-reported sleep abnormalities, and 1/4 screened positive for sleep disordered breathing. So this looks like an area that we need to work on, right? Need more knowledge here. Similarly, epilepsy, right? This is again borrowed from the literature of kids who had neonatal seizures. What do we know about them? Well, we know that the kids who developed epilepsy, you're more likely to develop epilepsy if you had a severely normal EEG background, severely abnormal EEG background for 3 or more days, had deep gray or brainstem injury on MRI, had an abnormal discharge exam, or were born prematurely. Those are all make epilepsy more likely. We also know that for those kids who were born prematurely, epilepsy sometimes develops later than for those kids who were born at term. Eric showed you this graph already. I'll just reiterate that kids with HIE and prematurity are often left out of the research. We had this big study that asked whether cooling would be helpful and found that in these late preterm infants, cooling was not helpful and might be harmful. There's a lot of work to go, room to grow also in terms of figuring out how is prognosis for preemies with HIE different than for term kids with HIE. We think generally it's probably a little bit worse, but we don't have good data on that front. And then acquired HIE, we are really, scratching the surface for kids who didn't, as Eric mentioned, as we talk about neonatal HIE as what happens right around birth, but if the child is a day old, then we treat them as if it's completely different. And whether they get cooled or not is really dependent on in which hospital they're cared for. We don't have a clear answer here. And so there's work to do in this front too. So other gaps? What kind of sleep problems happen with HIE? How long do they last? What are the best approaches to improve sleep? What predicts why some kids develop epilepsy years after HIE? At what gestational age should we start cooling? What are the better predictors of prognosis for preemies with HIE? And how does age impact outcomes and treatment? I think we probably left you with more questions than answers, but we're happy to try to take any questions if you have questions now about the current state of the evidence, and we're definitely looking forward to engaging in a vigorous conversation today around 4 o'clock with exploring uncertainties in HIE.
Okay, I'll pause it because I'm sure that there are some questions, but I was just going to say that we can come around with a mic. So please raise your hand and then I'll run around and see. Okay, great.
You mentioned different protocols for different hospitals on when and if cooling is done. What is the biggest difference that you guys are seeing between the hospitals, like as far as waiting or not waiting?
Do you mean for if they are perinatal, so right at the time of delivery, or what she had just talked about with those that have HIE as acquired later on?
Perinatal.
Okay. So honestly, there are a fair number of differences. I think some of the biggest ones have been maybe solidified a little bit by the new AAP guidelines that came out. But things like the cutoff for how much is too much acid in the blood, so that pH and the base deficit on those initial gases is actually different and continues to be remain different. Our hospital does something different than what the AAP suggested because we felt that there was good literature to suggest a different threshold. And so that is a big variability, I think, in who we are cooling. The 6 to 12 hours, so how long you have to start cooling, is one that the new guideline allowed for a little bit longer based off of one study that didn't make the cut in the mini that we, if you can believe that there are more studies that we didn't cover. There are, so that is one. So there are some hospitals that consider and do cool between 6 and 12 hours of presentation and don't stick to that strict 6 hour. But I mentioned it in my presentation, the way that we do the exam and the way that we determine who's moderate and who's severe has a fair amount of variability in it as well. And so unfortunately, I think the answer to your question is all of them. All of the criteria are somewhat variable, but
No, I would just say that, you know, some kids present in a way where it's clear that they need to be cooled. And at most hospitals in the US, they get cooled. And then there's a big gray area. There's a big gray zone. And for those kids who are in the gray zone, it depends where you are. And it depends who happens to be your doctor that day, who happens to be your neonatologist. So the more work we can do to get answers to these things, I think the more consistent we can get the clinical practice to be. I think that those questions, the neonatologists are pretty good at paying attention to those issues, right?
We are, but we aren't in every hospital either. And so I think that is a big piece too. So it depends on who your neonatologist is, but it also depends on who your general pediatrician is who's attending the delivery, or the family practice doctor who's attending that delivery that may have not seen HIE in years. And so I think we in the kind of core HIE neonatology field need to make it as clear as we possibly can who qualifies and who should be seen, so that people who aren't seeing these babies on the everyday basis are able to remind themselves quickly.
And I just want to add a caveat to some of this conversation too. Like a lot of what we talk about with the research that's ongoing, we get a front row seat to. And one of the things that I think is, been really beneficial, obviously, being able to elevate all of our experiences in this room of what we know are gap areas is, we have kids and we have families that express, kids that miss the cooling window or miss it for whatever reason, whether it's time or identification. We have the kids that, have the sudden unexpected postnatal collapse, the 6 to 12 or 24 hours. And then we have kids that are in that mild area. They're actually not mild, that when you get a continuous EEG on them, which was not standard until we brought the family perspective as well to these new development of guidelines for continuous EEG in monitoring. We know that these kids are actually a lot of them are having subclinical seizures. So the Cool Prime study, I was in the meeting yesterday morning with the collaborators. One of the key, whether we could answer the question of if cooling works for mild or not, one of the really key things of participating in research and doing this research is we will be able to hopefully influence improvement of care of getting EEG on earlier. And those kids that are, actually having subclinical seizures they're not mild. That automatically ticks you up to at least moderate to qualify. So we know that that's going to improve care and close gaps. So that's why this sort of collaboration and these conversations are so critical, because your experiences get elevated. The gap areas we know get elevated. And those papers that, my name is on are in conjunction with all of you in this room. That is all of you have studied, the surveys that go out that many of you participate in, that data is attributed. This community is driving forward that change. Just wanted to give that.
Thank you. We also have questions in the Zoom room as well, so I'll come to you next, but we'll take this one inside the room.
Hi, good morning. Thank you. Evan Rowe, HIE loss parent from Connecticut. I have a question about hearing loss. Our child was born 33 weeks, placental abruption, emergency C-section. All his care was at Yale University. Nothing sent the NICU into more of a frenzy with the doctors than at the 11th hour for the hearing screening right before discharge. Now, we were in there for months, and I was wondering if you knew of hospitals, is there a best practice of universal screening elsewhere in the nation, or is that another hospital by hospital practice? Because I'm certain there's a large subset of babies. We were there for months. That's a lost opportunity to check hearing while you're there. Then instead of waiting, a couple of days before discharge, and then, let's get ENT up here at the last minute. Now, in an ironic twist, his hearing loss had nothing to do with the brain injury, and it started improving. But I was just curious that's a missed opportunity there, to kind of catch hearing loss or anything related to that while you're admitted there. And kind of their response was just, well, it's our standard practice to do the regular tests for every baby that leaves at this juncture. But certainly there's a large subset of kids that the hearing loss it's happening right then and there, all those months. And then, and that's CMV notwithstanding. That's another caveat too. So I wondered if you knew anything anecdotally about hearing loss screening for NICU HIE babies.
So it's a great question. I think the core of the answer is there are universal guidelines for the hearing screen. It's not controlled by neonatologists, it's controlled by the hearing folks. And so they do exist, and they are a little vague in exactly when it needs to be done, but they usually do recommend close to discharge. And the reason being is not that it wouldn't benefit potentially having a baby screened earlier. It's actually a limitation in our ability to diagnose it earlier, because the way the technology that we have relies so much on some things that are both developmentally and time regulated, like clearing fluid out of their ear canal. Things like feeding tubes can cause that fluid to not be able to come out and can cause a false positive. So show that a baby has hearing problems when they don't actually, if it's done too early. And so there are a bunch of pieces. Some of like high flow can interfere with the actual readings. And so there are a bunch of things that we do for babies in the NICU in that early period where the technology we have just isn't good enough to be able to detect it. And so that's the main reason we wait till close to discharge. But yeah, I think that is definitely an area where the technology needs to improve in order to get better care there. So CMV testing, that is a much more variable. We do not have any national standard guidelines of who to test and when to test. I will say that I think the the time that the test is obtained is very clinician dependent, and so that is a huge area. Again, not one thing that we necessarily have already set up guidelines for, but probably should be. It's a good question.
Thank you. We have 2 questions now in the Zoom room, so we'll read those and answer them. I want to note that we're running short on time, so we'll take 2 more after that in the room, and then we'll move to a coffee break before our next session.
Okay, so this is from Lindsay. Is it expected to get a most representative SAMET score that the initial pH is taken from the umbilical cord remaining from mother? This is opposed to taken from the baby 1 hour later.
You guys keep picking on me. Do you have a neurology question in there somewhere? So actually, there's not a ton of data on this question, but there is some out of actually just down the road here in Boston, where they looked at paired samples and found that the postnatal, so at 1 hour of life, is as good, if not maybe slightly better, in predicting an abnormal Sarnat exam. And so again, we don't have a ton of data. It's a single center study, but they are both good. And the reason that's important is because sometimes we just can't get an umbilical cord sample, no matter how hard we try. And sometimes we get one and we send it off and there's something wrong with it, or it doesn't run correctly. And so being able to trust that baby one that we get within the first hour of life is really important to be able to make that diagnosis.
Thank you. And then the second question is from Sarah. The Worth It bubble visual slide was extremely interesting. Can you reiterate how the green, yellow, and red were chosen? And were studies referenced, or what was the ranking criteria that were used?
Yeah, it's a systematic review that reviewed systematic reviews. So they looked at all these systematic reviews and then analyzed all of them on a higher level. So it's like an analysis of an analysis, right? And then they went through, I think it's something like 1,500 papers on their initial screen, and then filtered out some based on, either they didn't, again, it's based on kids with cerebral palsy. So this is not based on kids with a diagnosis of HIE. This is based on kids with a diagnosis of cerebral palsy. So if the paper didn't include more than a quarter of the population in the paper had cerebral palsy, or they had multiple criteria for why they excluded certain papers. In the end, they included something like 274 papers analyzed within that bubble study. And then the size of the bubble tells you the strength of the evidence. So a big bubble means that there's at least 15 randomized controlled trials, those are kind of considered our highest quality of evidence, trials showing that this intervention or this therapy has some benefit. And so the big bubbles that are green are the ones that have the best evidence to support them. The yellow bubbles means that either the quality of the evidence wasn't as good or there weren't as many studies. And then the authors of the paper made a worth it line of where they felt those interventions or therapies were worth trying or not. The things that fell below the worth it line are not recommended at this point.
We've received this question in the Zoom room as well, but I just wanted to share in the room. We will be sending out all the slides after, and all of this is recorded. So you can watch this session in the future for anything you might have missed.
Yeah. Yeah, I had a question around kind of AI in terms of like things like reading MRIs and comparing outcomes, or just what's being done with AI in general around.
Our friend Paul Gross over here is working on those things. Paul, do you want to speak up?
I will say it's trouble to get funded, but one of our collaborators from the HIE registry is Zach Fasoulis, who's a neonatologist at WashU. And what we're trying to do is get, clearly when you get down to the voxel, the three-dimensional pixel of an MRI, and you're looking at a cluster of them, a machine's going to be able to see things that the human brain can't take in. And so we are looking at that as one of multiple modalities that we would evaluate to see if we can predict outcomes. And we're focused on CP as an initial set of predictions. So it's looking at that, it's looking at genetics, it's looking at the registry. It's, and we'd love to add EEG to that. And so, but we have not, it was very interesting submitting it to NIH. And so we're now looking for a new funder. So it has not, we've got the design, but it has not started yet. There are other groups. There's a great group in Georgia that is doing a ton of things with sort of machine learning on MRIs. They're not focused in this disease space. They'd be willing to collaborate, so there's a lot of possibilities, but I don't know of anything going on in this disease space right now.
Thank you. We'll take one last question here, and then all of you can get up and get some coffee.
Just want to say real quick before we add on, the one thing I wanted to add on to that, and that's absolutely all accurate, is one of the difficulties that we have with utilizing AI is we don't necessarily have a gold standard for the diagnosis. And so when you're going to train the model, it's a little bit tricky to train it correctly. And so asking an AI, does this patient have HIE? You have to have the data to support that this is what HIE looks like exactly. And so all of those things that we were talking about of the lack of a kind of standard diagnosis makes it a little bit tricky to truly use AI to its fullest. You can, but then you're assuming that those diagnoses were accurate. And that's where we fall short is, again, without some of those may have, just because a baby was cooled doesn't mean they actually had HIE. They had some form of neonatal encephalopathy that looked like HIE in the first 6 hours. And so the criteria used to select that population is a little tricky. But I think there's lots of people trying to use it to help power our field for sure.
Mike Medved from Pittsburgh, Pennsylvania. Thank you both so much for being here and sharing your wisdom and your life's work with us today. It's just incredible to be in this space and hear from you two. I'm curious, as far as what would be like the percentage of hospitals that have the capability of cooling, as it is kind of the one well-respected method at the moment? And if parents in the room wanted to kind of advocate to our regional or city hospitals to maybe become capable of cooling if those hospitals are not already, what would like the cost benefit analysis look like? Maybe as it relates to like having an AED in public spaces. What kind of tools or wisdom could you share with us? As being in Pittsburgh, we have a great medical history. It's kind of replaced the steel industry and all that. That being said, my son was born at a regional hospital and then was transferred after having a seizure at 13 hours and missed the window by the time he made it to Children's Hospital of Pittsburgh. So just curious, to kind of help families that have not yet gone on into this journey, what we could do to advocate for having cooling and staff certified, as it is kind of the one currently accepted treatment.
Yeah, it's a fantastic question. I think using the kind of the AED analogy that you started with, I think it's really beautiful because I think it does mimic kind of what I think the model ultimately will and should be, which is early identification and early management. So the AED is not going to fix the ultimate problem, right? It's going to stabilize that patient long enough to get them to the place where they need to be. And I think that's really what we need to be advocating for in kind of regional and smaller critical access hospitals. So in Nebraska, the vast majority of our hospitals are small critical access hospitals, and it's just not feasible and probably not safe or right for those patients to be splitting up therapeutic hypothermia to all those hospitals. And so what we've really focused on, what I think the focus moving forward should continue to be, is getting education out to those providers to make sure that they know how to identify HIE, how to manage it in the delivery room, and for the first however long it takes for our transport team to get there, that our transport teams know how to manage it and be able to cool on transport, and that they can get them quickly to a place where they can get that ultimate level of care. Because ultimately, we can't replicate the neonatal expertise, the neurology expertise at all of these different hospitals. That really needs to be there to provide the best care for these babies. Correct. So there, some will do passive cooling in the delivery or in the early period where they turn off the warmer and just check the temperature really closely to try and keep them there without an active cooling device. There are cooling devices that can be taken on transport, and many hospitals are using those. And there are some research studies that have shown that at least the temperature management is better when you're using the active cooling device. And so, yeah, absolutely. I think the education part is really where the core is. The transport cooling device is great. You can do cooling with passive, but I think the people who don't see HIE on a regular basis having that front of mind at all of their deliveries, that's the key component that I think a lot of times we're missing.
Thank you so much. When I signed Eric and Danielle up for this session, I was like, I knew it was a big one to describe the whole state of HIE research in 1 hour, but you did such an amazing job. Thank you so much.